Hey guys, welcome to class. We are going to be talking about the difference between volume control and pressure control today. You can see on this slide the pages if you need them for Lindsay, Jones, and Chang. This will be a 15-minute lecture purely because Screencast-O-Matic gave me free 15 minutes. I'm not paying for the trial. And then after this, there will be a short assignment. It'll be easy, basic. You'll be able to figure it out. I'll type in the instructions and everything. We also have a special guest. Artie is here with me today, and she's been a good girl, and she wanted to tell you all hi and to stay warm and safe with this big storm. Your event sessions I will get to. I'm going to breeze through a couple of these slides because I only have 15 minutes to cover a lot of information. So your event sessions I will get to some point today. Your quick check-in, again, this will be part of your assignment. With volume and pressure control, these are specific to assist control and SIMV modes of ventilation. So control modes of ventilation will specifically be a subcategory whether you want this to be delivered in a pressure or a volume situation, the controlled breaths. You can either use pressure or volume, and there are a couple different factors that would determine what you would pick for this patient. We could be determined by pulmonary pathology. One example would be obstructive patients love pressure control. For some reason, their lungs just find it very comfortable to get that additional pressure in. It helps decrease work of breathing and increases ventilation. Patient comfort. Some patients with super sick lungs might need help just getting that volume in. They might appreciate volume control. Others like the fact that tidal volumes vary with pressure control. It all comes down to assessing your patient, which I know you guys are probably sick of hearing me say all the time, but assess your patient, see what they need. Another would be hospital culture and what your doctor is comfortable with. So in the two main hospitals in the area, the University of Utah and Intermountain Healthcare, Intermountain mostly uses volume, the U mostly uses pressure. Both are fine, both are appropriate. I want to teach you guys both so you're proficient in both, so that you are just this nicely rounded, ready to go respiratory therapist with their toolbox full of tools ready to help your patient with whatever they need. But just know that can be a factor. I've had a couple of you ask which one's better? And honestly, they're both equal, pressure and volume control. It's both preference, what you're comfortable with, what you feel you can best ventilate your patient on, and also what your patient needs. Also, acid-based balance management. Sometimes you need a specific minute ventilation, a very specific minute ventilation, so volume control is appropriate. Or you are having a hard time with volume control, your patient keeps fighting the breath, and you need pressure control in order to adequately ventilate it. There's different options for you. Initiate the mortal combat between volume control and pressure control, because we all know Sub-Zero is stupid, especially today. Volume control. This is a calculated tidal volume. We use our predicted body weight calculation, and there will be some other slides coming up a little bit. Every time we either deliver a mechanical breath or a trigger breath, we give that same volume of air for each tidal volume. But to kind of make things a little different, each breath has a different peak pressure. This can alter to accommodate for the tidal volume. So what's going on in your lungs is pressures are varying in order to receive that volume of air that you have set and are delivering. Pressure control, you have a measured peak pressure, which is delivered in centimeters of water pressure, and it will deliver that tidal volume up till we reach that pressure, but then each individual tidal volume will vary slightly within a range. but your peak pressures will maintain the same. Volume control continued. This can be either used in assist control or SIMV. Shocker, I think I've written that 3 times already. Refers to what type of tidal volume is delivered. So, sorry, I have a little typo there. It should be 6 to 10 mils per kilogram. Calculated, a lot of when you're working in the hospital, it's ideal body weight. Just focus on predicted body weight because that's what Lindsay Jones will use. And most of the time, ideal body weight, you have other resources that automatically calculate it for you when you're working. Each calculated tidal volume is delivered with each mechanical or trigger breath. This is mostly just a repeat, but that's how you learn sometimes, is repeat. So since the entirety of volume is delivered, peak pressure varies to reach each volume. So why would we pick volume control? There's a couple different reasons. ARDS ventilation. We will touch on what's called the ARDSNet protocol when we talk pathology. We will talk about ARDS, and you want very specific ways of ventilating ARDS per this national protocol. You will do lower tidal volumes, and they'll be calculated to help your patient, and that kind of goes into the second one, where we want specific volumes delivered to our patient. This might come in with a neurological patient that hit their head. We need a very specific CO2, so we'll throw them in volume control so I can actually have hard numbers calculating to try to find a set volume, a set minute ventilation, instead of a little bit of a range where, say, my patient took a deep breath and their compliance changed and we had a little change. Volume control is also great for ABGs that are difficult to manage because, again, back to the objectivity that comes in numbers. Hospital culture, whatever your physician or you are comfortable with in order to appropriately ventilate your patient. And pulmonary pathology. I had a patient one time. He was a lung transplant where I could not ventilate him in pressure control because his lungs were so garbage. He was non-compliant with working with respiratory and a whole bunch of other things. He fought us a lot and wouldn't do his treatments, so his lungs didn't stay very healthy, where we had to use volume in order to get any type of volume into his lungs, where normally I can ventilate most people on pressure. So again, it's very individual. You get to kind of pick and create your own adventure and help your patient the best you can. With pressure control, again, repeated information. It'll be either assist control or SIMV. We will have the desired PIP, which will determine the tidal volume. This is measured in centimeters of water pressure above the PEEP. So it's pressure above the PEEP. But we will still refer to the difference between PIP and PEEP as the change in pressure, or the delta P. You will have some small variations in tidal volume, which is pretty common. It's normal because your tidal volume will vary, but your peak pressures will stay the same. This can come from compliance issues, fluid management, intake and output, what's going on with the patient there, if they're kind of stenting their chest at all. This can alter your tidal volume. There's lots of different things. So why would you pick pressure control? Controlling peak pressures, such as decreased compliance, because those lungs are getting stiff. I like to think of them as they're getting really stiff. They can't move. So instead of trashing them with high pressures that might cause damage to the lungs, we want to control those peak pressures to help those lungs heal. Early stages of ARDS might be appropriate because you want to keep a low peak pressure but a high mean airway pressure. Hospital culture, you want specific pressures delivered to the patient. And then patient comfort. A lot of patients like pressure control because they can take in what volume of air they want. Because if you think about it, every breath you take isn't exactly 450 or whatever milliliters. You might breathe a little shallow for a second, and then around 200, and then you might take a big breath and sigh and take an 800 milliliter tidal volume. And so that's why a lot of patients will find pressure control comfortable. Another is pulmonary pathology. Again, a lot of obstructive patients, atelectatic patients really like pressure control. Along with volume and pressure control, you will set the flow. And this is determined how quickly inspiration occurs. This is between 40 and 60 liters per minute normally. That's a normal range. We can alter I to E ratio, so we can either have a higher flow, closer around 60, and that would give a little bit longer exhalation time. But you have to be careful because with higher flows come higher peak pressures. Because think of it as our sink analogy with the cups and the water, and where you turn the sink on. If you do it too high, you might have higher pressure enter that volume. Whereas if you have a slower flow, that's great. It allows for longer oxygenation time, but it also will help control peak pressures. You can adjust. Also, I mostly adjust when I have a patient volume control. I adjust my flow based on comfort. You'll also see the V dot max if you guys, with a little V with a dot on top and max. That's your flow. That's just their fancy verbinology. And then pressure control. Hey, that's a fun word. We're going to use that as our secret word, verbinology. That'll be part of your assignment. I wanted to throw it in the middle here to make sure that you guys actually watch this video and actually watch this lecture. So part of your grade on your written assignment will be that, verbinology. Pressure control. We set an inspiratory time. This is an actual measured time during inhalation, measuring inhalation that is dependent on respiratory rate. And again, we can manipulate it depending on pulmonary needs and IDE ratio. So you can always check that, but every individual breath the patient takes will be the set time you set that is delivered by the machine. One thing I want you guys to note when you're trying to determine what is more appropriate, volume control or pressure control, is that sometimes not what you deliver is what is measured on exhalation. And be careful about this. Because again, there might be a compliance issue, you might have a leak, you might have something else going on physiologically or mechanically. Always check your ventilator too when you're checking your patient. I always say move from the patient out. Monitoring exhaled volumes and measured volumes is very, very, very important in determining whether you want volume or pressure control. Just remember that the ventilator is a closed circuit, so volumes are directly measured based on exhalation. So as your patient exhales, the machine takes those exact values and numbers of the volume of air and measures it. The norms. I'm going to kind of breeze through this because A, it's in your book, and B, we kind of talked a little bit about it last week. So our rate, we want to just make sure our rate stays less than 30 with patient trigger. You typically won't set your rate around 30 except for very sick or very specific patients, neuro patients. So I'm just going to actually just skip past this. You want your peak pressures less than 30. That's the other one I want you guys to know. We are going to skip the scenario. If you guys could just kind of read through that, part of your written test will be some of your thoughts on this scenario I have in here. And this slideshow is posted on Canvas. So our 15 minutes is just about up. Do the written assignment, and I want you guys to stay warm and stay safe with this snowstorm coming in. And thank you for accommodating the needs. I just didn't see the point in risking any of our safety because we have technology now, and that is fabulous. So you guys have a good day. All right. Okay, bye.